we've glossed over the Castor and Pollock studies of daratumumab because they weren't really updated at this meeting. Have they established, along with your study now, daratumumab as going to be incorporated with pretty much every regimen we use, you think? Is that where we're heading here?
Yes, I would say.
I think the data in first relapse is so strong for DARA. I think the question is, what's the partner? And you mentioned 15 months for KD. You know, for the POM DARA-DEX that Ajay from our center presented in first relapse, it was about 14 to 17 months was the PFS. So it really is, what partner do you want to choose?
What about duration of therapy at relapse? We're using these triplet regimens. When do you decide to stop, Ed? You had they all have very high response rates, 80% higher. What makes you stop or start to cut back on?
Yeah, I mean, the discontinuation of therapy is driven by response and by toxicity, more so than a set endpoint. I am so impressed with how well, beyond what I anticipated, for instance, the daratumumab is tolerated by patients. I quiz them on this every time I see them. And once they get to once a month, they are impressively comfortable with doing that. And as you alluded to earlier, it's sometimes even more difficult to give lenalidomide for long-term or
Actually, that was
bortezomib.
Tom. I didn't say that, just to be clear.
Well, usually it's Tom.
It's California over there.
Yeah.
So I would say that out of the triplet regimens that we use, the most toxic drug is dexamethasone. So in fact, that's probably the drug that I decrease the dose in first and also get them off first is typically dexamethasone. And then between the other two partner drugs, you know, both tend to be potent these days. We have really potent drugs, and it's really, what do I attribute the toxicity to? This drug, drug A or drug B, and that's the one, whichever it is, that's the one I'll reduce, and the other one I'll just continue. It's kind of fun, and I think you can get to a very tolerable regimen that patients can take year in and year out.
Is there a stopping point for relapse therapy, or is it really until progression? Because is there any point which you say enough's enough, other than toxicity?
I would just make the caveat that in high-risk patients, I'm not as prone to discontinuing, because I think the response rates should be distinguished from PFS. And high-risk patients may respond well, but we know that they relapse faster. And there, I really try to maintain them on both of the active drugs, not necessarily the steroids. But I think for other patients, you know, I think what you've been hearing over and over is we have a dearth of MRD negative decision-making studies, which, so if you attain it, how many drugs do you need and for how long? That's what I think what we really need.
I guess that's the question for me. If you use daracarfilzomib and you're MRD negative, do you really need to go forever? Do you drop one of the drugs and just continue one? Those are the things we just don't know the answer to.
And in our current circumstance, our relapsed regimens may be even more potent than our initial regimens.
Exactly.
But that may change over time as we move these more potent regimens.
Second transplants versus continuing the drugs?
Yeah.
Certainly cheaper.
Yeah, it has become cheaper. There definitely is a role for a second transplant. A lot of it depends on the behavior after the first transplant and durability of response, toxicities, et cetera.
We're going to get really complicated now. What happens at third relapse? You've now used 6 different drugs. And are you just recycling prior things, or is it time to move on to novel mechanisms of action? Sagar, what do you think?
Yeah, so, you know, for us it would be darapom in first relapse, and then second relapse would be usually CAR plus cyclo. So we go old school in that situation. And it's
that was some shade thrown at me, by the way. I got that.
And then again, start to think about recycling as well, and looking more closely at genetics. And I think, you know, for instance, I'm not going to argue that mutation-driven therapy should take over at third line, but a lot of people weren't testing for 1114 5 and 6 years ago, and that's a great opportunity if they're 1114 to think about something like venetoclax.
Any other thoughts on sequencing therapies and how we choose our regimens in later relapse, Amrita?
Well, I think it's shifting so quickly, as everyone alluded to, because now we're going to use a lot more POM first relapse. We're using DARA first relapse. So
or up front.
Exactly. So it becomes, I think by the time you get to third relapse, you really are just mixing all the ingredients. But we've used a lot more venetoclax now in combination with bortezomib. As you know, phase 2 trial published showing about an 80% response rate, and
Yeah, I think we might come to that a little later in our discussion, but venetoclax is certainly a drug that's beginning to appear in our conversation. Anything else that's...
I think the two sequencing, again, this is a dearth of issue because we really have very little sequencing studies. Right? If you do this, then you should do that. But the two things I would say is, number one, elotuzumab has a sequencing issue because it's only on label with LEN. So
thank you for mentioning ELO, yeah.
if somebody is not LEN sensitive, there's really no on-label use of ELO right now. And I think the other, I'm sure we're going to get to this more, but the BCMA is now becoming an issue as well.
So actually, I'm glad you mentioned ELO, and I apologize we haven't talked about that before. Is that a good choice when daratumumab has been used and maybe failed? Would you consider elotuzumab?
I think the ELO struggles with having lack of single-agent activity, but its strength is its excellent tolerability. And I think that those of us who've done the ELO studies, we all have patients that have been out many, many years, 6, 7 years. We had patients on ERD without really any problem. I think the question is who is the right patient? And I think somebody with perhaps biochemical relapse and LEN sensitive or maybe LEN maintenance low dose, I think that's one role for ELO. But once they progressed on LEN and or fulminantly progressing, I don't think there's the role for ELO.
But if DARA moves up front, then ELO may have an opportunity in the relapse
Yeah, I
setting.
guess that's what I was asking. Do you think it opens the door for ELO to come in? And
Yeah,
And
may
there
be-
are other regimens with ELO now. So there's ELO POM dex, and there'll be ELO exazimib dex. There'll be other combinations that we can see if there's a good response rate that can be part of the sequence. The only thing I would add is when we're done with PIs and IMiDs and daratumumab, at that point in time, I think that the options are really alkylator-based therapy. That's when I tend to think about, am I going to do a second transplant? Sometimes I'll give them chemotherapy to get them into remission and then do a second transplant at that point in time. Or the other drug that I do get some responses from is bendamustine as a quote-unquote alkylator-based regimen. And that's really kind of down the road. I think all of us practice that those patients are on our next immunotherapy clinical trial, because that's the eligibility now for all the clinical trials. But other people in practice, I think those are things that they can do, is they can do the alkylator-based therapies.
Can I make a case? The other thing for second transplant, because we talk about tolerability of these regimens long term, which is fine in terms of neuropathy, cardiac, but the one thing you can't mitigate against is hematologic toxicity.
Right.
And that is actually often a case where we end up doing second transplant to reconstitute counts. Maybe you're also having some resetting of the immune sort of
Transplant becomes a
environment.
bridge to another therapy.
all right, well, I think we've heard that treating relapse is complex. We're using pomalidomide and carfilzomib and daratumumab at first relapse these days in various combinations and cocktails based on prior response and patient characteristics, tempo of relapse. But clearly, any of those combinations improving outcomes for our patients, and we need to learn a little bit more about how to best combine them and for how long to use them.